Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning into the podcast. Today, I'd like to talk a little bit about IUDs and some new changes that are coming out from the CDC around that. Before we get started, please do me a favor, go down there and subscribe. That means a lot to us, lets me know that you like our material. Feel free to comment and like and share as well. And let's get started. So the CDC has finally released recommendations for the pain management and pain control for women who are receiving an IUD. Shocking. How many decades has gone by with them not doing anything about this? This is a traumatic experience all these years. And women have not had adequate pain care or pain management for this procedure, rendering this procedure traumatic. And it doesn't need to be. Many women are put on oral contraceptives at an early age, and they're being put on oral contraceptives because that's the only way that many doctors know how to manage PMS and PMDD. That's it. And they're put on oral contraceptives and parked there and left there. And we've talked about this before. I don't need to dig into that again today, but I want to preface today's episode by mentioning this. So when a woman presents to my clinic and we're going to try and resolve what causes her PMDD or PMS, when I'm going to now get to the bottom of why they're having this dysfunction. Generally, it's anovulation and it's low progesterone. That's the most common thing. There's other things that could play in there as well. But a part of that is we get them to discontinue oral contraceptives because they don't need it anymore. They can go back to having a normal cycle. And I'm not a maniac who steps in and says, oral birth control is bad, get off it today. That's ridiculous. That's not healthy. If a woman comes into clinic and the only thing that's keeping her stable is oral contraceptives, you don't kick that leg out from underneath them. You get a solution in place first, and then you go to the next step of removing the contraceptive. So it's being responsible as a physician, and we create the balance in the patient. We get resolution of symptoms, and they no longer need to be on oral contraceptives. And the reason why I'm opposed to oral contraceptives, or one of the reasons why I don't like it, it's not that I'm opposed to it, because there are times you need to use it. I know this. I just don't like it being used in a lazy format, and I also don't like women to take it without them being aware of the significant side effects that it causes. Increased sex hormone binding globulin, long-term causing lower levels of free testosterone. That's a serious issue with women, and the impact that has on brain chemistry and libido, the impact it's going to have on your liver, the synthetic hormones on your liver. There's a C-reactive protein inflammation throughout the body. There's a lot of things about oral contraceptives that women are never told. When a woman is on oral contraceptives and we transition them off of it, we create a better balance. They're having a normal cycle again. They're no longer having the excruciating pain or the mood changes or the combination of mood changes and excruciating pain. What are they going to do for contraceptives? That has plagued me as a physician for 20 years. 20 years. Because what do I tell them? Contraceptives or condoms? Condoms work to a point, and then you have to trust your partner in condoms. It's not always going to happen. It doesn't work always. And then what else do you have? What other options do you have as a woman? I recommend vasectomies. I've done a lot of vasectomies in my career. And I'll tell you, that's one of the easiest procedures you'll ever do. It's really easy. It's you're in and out real fast. It's superficial procedure. It's not deep. You're going to go deep in a body cavity. You're not doing anything crazy. It's not like you're tying someone's tubes. You know what I mean? You're just right there on the surface of the testicles there, and you numb the area and you just do it. But your compliance or having husbands come in to do that is very low. So again, this is something that's taken out of her hands. So what do we do? What else can I offer them? There's the IUD. There's a copper IUD that I prescribe a fair amount, and I used to do them a fair amount in practice as well. The thing about inserting an IUD into a woman, especially a copper one, is that it's an uncomfortable procedure by nature. And that's the nature of today's episode. It still sits in my head all the times I've done IUDs. The procedure is difficult. And this is important. The procedure is difficult because you have to go in there and you have to, again, have access to the cervix. Then you have to manipulate the cervix into a position by holding it up with something called the tenaculum. And a tenaculum is a spiked tool. It's like a forceps that have spikes in it, and you have to penetrate the cervix. And that penetration, you penetrate both sides of the upper part of it, and you have to pull it up to get the correct angle. So now you're puncturing a woman's cervix with a metal tool, a metal instrument. And you're applying traction to it, you're pulling it upward. Then you're going to measure the length of the os and the position you want to put the IUD in. And then you're going to insert the tool, the IUD insertion device, through the os, or the opening of the cervix. And that opening is not open. You have to push through it. For a woman who's never had children, that is a really difficult thing to do. Picture yourself in a room, and you're having you're up in the stirrups, and your doctor, at this most sensitive, most personal part of you, using an instrument that's punctured two parts of your cervix, which is a very sensitive part of your body, and applying pressure and pulling it upward, and then putting something through your cervix that has never had that happen to it. Even when we've had children, that the os is a little bit more open or able to be penetrated, it still is barbaric. I want you to know I've never done the procedure that way, by the way. Never, not once. Not once. Because it's barbaric to do it that way. Which brings me to this. In medicine, the common standard of care for women when it comes to an IUD is to insert the IUD without anesthetic, without anything to soften the cervix, without anything to lower her anxiety. They just go in and just raw dog it. They just throw it in there. And to say that that's a traumatic experience for women is really putting it mildly. So when the CDC, just the other week, released guidelines recommending that doctors talk to women. They're not even telling you have to do it, but they're saying just talk about it with women. Pain management with this, that's huge. It's huge. But what is this? The Dark Ages? You know what I mean? How long have we had the technology? I mean, I can't even call it an IUD technology. It's just a little device, a little plastic thing that's ring and has copper wrapped around it. I can't call that a device. It's like it's a piece of medical equipment. It's been around for a while. Even doing IUDs the way that I do them, it still is a sensitive and traumatic experience for women. So, sadly, how many millions of you have had this done? Worldwide, 159 million women have IUDs. Worldwide, 159 million women have gone through a barbaric procedure. So how can it be done differently? This is the important thing. This is what I want to talk about. In my practice, when I have patients who are going to go in for an IUD, what we do is we give them a checklist of the things they should be having done before, during, and after an IUD insertion. And these are non-negotiable. I tell my patients, this is a non-negotiable thing. If your doctor will not do these things, they're not your doctor. They're not even a doctor, in my opinion. So these are your things. The day before an IUD, or the night before, the patient will take antibiotics and misoprostol. Now, misoprostol is a medication that's used called as cervical ripening. And when you take it, it softens the cervix. It allows it to be more open. It allows us to have better ability to insert the IUD through the os. So that's very important that we prescribe that misoprostol. That's a critical component of it. And if the misoprostol was not a high enough dose or it didn't work correctly, I'll see it the next day. So I'm doing the procedure. If I see that her cervix doesn't look like it really is softened, it doesn't have a certain look to it, and if it doesn't have a certain feel to it when I'm trying to insert the device, I reschedule it. I will not traumatize a woman's body. I will not traumatize a woman's body. The day of the procedure, the patient will take a benzodiazepine, and I generally prescribe Valium. That's my go-to there. That's diazepam's not a bad one. They'll be driven there by someone. They take the diazepam, and then that diazepam, what it's doing is letting their body relax. It's an anti-anxiety agent, but it's a physical anti-anxiety agent. Everything just calms down a little bit. And that's important because I am in one of the most private parts of you that there is. And I need to treat it that way the best that I can as a physician and have that relationship with you. You know that I see this through that lens and I have that care for you. And I need to earn that trust from you that you feel safe with me in the room. But even then, with that trust and that sense of safety, you're still a human being and this is still your body. And what we're doing is pretty unnatural if you think about it. I'm going to be using this moment to insert a device into you to prevent fertility temporarily. So benzos like diazepam work great. What else do we do? During the procedure, in the very beginning, before I even think about taking the tenaculum out to use, before even any of that, I will do a cervical block. And that's when I'm going to inject the cervix with an anesthetic to numb it completely. While I'm injecting the cervix with the cervical block with the anesthetic, I'm looking at the cervix. I'm seeing whether it's ripened, seeing whether it's soft. There's a certain look to it that you could tell whether the medication is working. That's my first view of that. The second one is when I do the insertion, I'll know because either it's going to insert easily or it's not easy. If it's not easy, we don't do it. We reschedule. Once I'm able to numb the cervix, once I'm able to have that, once I know that the cervix looks like it's ripened, when it's soft, when I'm able to use these tools without harming her, without traumatizing her body, that's when we start the process. And that's when I take the IUD out of the package. That's when things are happening. That's when we're going to insert that IUD. When we do this procedure, it is done. The patient is awake and alert. They're still on a benzo, of course, but they have someone bring them in there. There is someone here to take care of them. I'm in the room with my assistant, and I do my best to make sure it is a sensitive moment to them. The lighting is dimmed in their area, and I have my lighting down here that I need, but she doesn't need bright lights in her head. Looking straight up into fluorescent light doesn't really help any human being ever. We insert the IUD, make sure that I have it in the correct position just by doing my process that I have in the room that I know to do. Once the IUD is inserted in the patient, we do our post-op, we do our care with her, getting her ready for her to go home. She's driven home, and then I schedule her for an ultrasound to see whether we placed it correctly. Now, some physicians will have that in the office themselves, and they'll do the ultrasound to ensure that it's in the correct position on site, and that's actually a better way of doing it, in my opinion. But once it's there, and once it's in place, you'll have that in there. And some IUDs last 5 years, some will last 10 years. Depends. An IUD does not have to be a barbaric thing that traumatizes you. You deserve better. I want you to request better, demand better. It's so easy. It's so easy to take a misoprostol the day before. It's so easy for me to inject lidocaine into your cervix that day. That's so damn easy. It takes no time. And taking a benzodiazepine is nothing for this. People take a benzo to fly on an airplane. I mean, they're not great to take all the time. And of course, I write them very sparingly. I only write when I specifically need it, and it's only for the moment they need it because, man, that stuff is very addictive, benzos, if you do enough of them. But this is the moment you do use it because this is what it's for. I hope this helps. Write it down on a piece of paper. Antibiotic, misoprostol the night before. Benzo the day, the right before the procedure itself. Someone drives you in. The doctor, cervical block, injecting the cervix to make sure it is numb before they touch you, before they insert anything into you. The lighting, that is important. The sense of feeling safe, that is important. I know not all of you can get that. I know not all of you have the environment around you that'll foster that. I believe that by creating demand, you will create people who will fulfill it. I think by you demanding it, I think that will cause there to be a change. I want that. That's where my hope is for you. I hope this helps. Please like and share. Please share this. There's so many young girls, but this is the only option they get. There's so many young girls that this is such a traumatic thing, and it's so rare that they talk about it. 159 million women. Even doing what I've done, the procedure, it still is a very sensitive procedure for women. You deserve that. You deserve that care. All right. I hope this helps again. Thank you so much for tuning in. I'll see you at the next episode.